There are obliques for T-spine. They're extremely rare. I doubt you'll ever do them. It's kind of a wild oblique. It's almost a lateral. It's a 70-degree oblique. This is just how the zygophyseal joints are positioned in your thoracic vertebrae. Centering's the same. Just remember it's way different than the other one. The zygophyseal joints, or the Z's, are going to be at a 70 to 75 degree angle. So they kind of look like a Z or a slash. It's important to remember what you see on a lateral for all of your spines versus what you see on an oblique. T-spine, lateral, remember you're looking for the O's, just like lumbar spine on the lateral, you're looking for the O's. Remember that cervical spine is your outlier. The cervical spine, you're not looking for the circles, you get the circles on the obliques. So find a way to kind of remember those. Are you looking for circles or not? That's important. Some considerations for T-spine positioning. Your textbook will go into defining what a compensating filter is. If you could use one, we don't have those at our clinical site, so you won't see them in use. But they would be something that the department would purchase, and you would put it on your tube when you're doing an AP projection of a T-spine. You will see some orthostatic breathing techniques used, increasing the milliseconds. The lead blocker behind the patient just helps with some backscatter, things like that. Something important to remember is that the thoracic vertebrae is located posterior, so please don't let me see your T-spine look like this. This is supposed to be a chest x-ray. But just remember your T-spine is posterior, so you're going to come back a little bit from midline. Lumbar spine, we don't come back as far, but T-spine really makes this curve. Also, try not to collimate too tight. If it is this rounded one, especially if they're kyphotic, don't go too crazy. This is a really horrible example of someone not using a breathing technique. The ribs are completely overlying. This is a really horrible picture all in all. This poor number 15, I don't know, they're going to go down in history. But you'll see the ribs clearly if you don't do a breathing technique. This is a very kyphotic patient. You can see how their whole upper back here is almost folded over. Their neck is going to come up this end here. So it does make it a little bit harder to collimate tightly, but just being aware that it is going to be posterior, but it's a really clear, beautiful x-ray. Right laterals, I would say most of your texts do not do them, but if you get a chance to do a right lateral instead of a left lateral, you utilize the anode heel effect. And I know you guys went over this a little bit in equipment, but the only way for me to remember it is fat cap. The fat part goes under the cathode. All right, so those thick shoulders, when they're in the lateral position, that's going to go under the cathode end because the cathode end is more intense than the anode end. Why? Because of the angle of the anode. So these X-ray photons that are coming over here, they've got to get down this angle and then out. So they're a little less intense than those here up here at the cathode. All right. If you do a right lateral, remember to use your right marker. It's going to throw you off the first time you do it. How do I remember anode positive, cathode negative? I want an A+ in class, not a C-. I also only remember as fat cat, put the fat part under the cat, or the cathode. Okay. This was just a demonstration of using the cathode end versus the anode end for an AP T-spine, and just showing you density-wise and uniformity-wise. Breathing technique. What does the breathing technique mean, and how do you do it? And it's a little bit different on each machine, but you're going to set an MA station in milliseconds, ideally over 1 second, to create a breathing technique and blur out the ribs and lung markings. Your patient's going to be breathing through the entire exposure, and you're probably going to panic at first when you hit the exposure button and it just kind of goes for a while, because you're used to that short exposure, and we'll talk about that in lab too. But just remember, going back to basics, how do you calculate your mass? You do MA times time, and remember milliseconds, you got to move the decimal. So if you're in the millisecond setting, you have to remember how to get to seconds and figure out what your MAS is. Each piece of equipment, of course, is going to be different. So our ER, you can only get to, I think, 1,000 milliseconds, which is 1 second, which makes it super easy for calculation purposes, right? If I have 20 MA in 1,000 milliseconds, you're just doing 20 times 1, and that's super easy peasy lemon squeezy. And then, so Main Street, I think we can get up to 3,200 milliseconds. And then miscellaneous, I don't think we can set our milliseconds really much at all. It really doesn't go over, I think it's 2 seconds, and it's really super finicky. So it's going to depend on the equipment and your ability, and you're just going to have to go through it in the area that you're in. I tell my patient to breathe normally if I think they can follow instructions. If they don't, then I don't say anything to them at all, and they just continue to breathe, and it works perfectly. Something you may see when you're doing a lateral T-spine, you might notice these kind of white blocks filled into their vertebrae, and that is post a surgical procedure called a kyphoplasty, and you may see them in your OR rotations. But it's usually the patients that have compression fractures, and the surgeon will actually make this sort of mixture, a cement usually mixture, to give the vertebrae some strength, and they will insert a balloon, inflate the balloon to create an opening, put the mixture in, then the cement stays there and helps solidify the spine and help with the patient's pain and also spine stability. A spinal cord stimulator, you will definitely see these in our OR being placed, or when you're doing any outpatient x-rays. But if you see this in their spine with some wires coming out, that's a spinal stimulator. It's usually for pain, and it sends these electrical pulses to modify your pain that you're having, and they can control different levels or whatever. Spinal fusion. I've never seen one this crazy, but you know, that was a fun picture. I've never seen this many vertebrae fused, but I'm sure it's possible. They may come in post-spinal fusion for some x-rays. It may be required upright, so just watch your orders. Scoliosis is something you'll see on any of the spines, but it may be a C shape or an S shape, depending on where their scoliosis lands. Thoracolumbar is an order we don't get very often. And what the thoracolumbar order is, essentially, is they want to see from L5 as high up the thoracic spine as you can get. You are not going to get a full T and a full L spine. It happens a lot where the ordering doctor actually doesn't realize that, and they sort of get partials of both. Most of the time when they actually want this order, it's because the patient has a fracture somewhere. They're in a back brace, and they want to see how stable the spine is with them standing up in the brace. And it looks like this. It's called a TLSO, or I call it a turtle shell. But it's a thoracic lumbar sacral orthotic brace, and it usually helps patients that have had spinal fractures to sort of stabilize the spine and still be upright and walking around. But if you see this, it's hard plastic. You're going to have to increase your technique to get through it. The next few pages here are just anatomy, so go through the anatomy, back through those rib articulations, the facets and demifacets where the ribs will articulate. The spinous processes are pointed caudally. Just note that. I know you guys have already sort of done this anatomy with ribs, but make sure you go back through the joints, the costovertebral joint for me, the costotransverse, where are they located, can you find them, rib attachments, just anatomy, go back through. All right, spine anatomy. Everyone tends to confuse the pedicle versus the lamina. All right, find a way. I don't have a fun way for that yet, but I just remember pedicle is closest when lamina is towards the spinous process. If you have a fun way, let me know. And that was just another one of the obliques. This is just showing you where the zygophyseal joints are in this 70-75 degree range, and versus the intervertebral foramina, which is true lateral, gives you the 90 degree. And that's it for T-spine.